have questions, and I'll take that probably in the end, but I'll go with, it's a case, and I want you guys to see how we use the radial as laser as was created through the dual axis. So thank you, and thank you everybody for having me. These are my disclosures. So 7 years back, somehow, I was under one of those episodes, and I thought about creating something called MALI. And what that stands for is Minimal Alternative Access Lower Extremity Intervention. So 7 years back, talking about an endovascular procedure through the radial or the pedal. Well, pedal is common, but radial was maybe not unheard of, but was not thought about. I'm going to go through my protocol a little bit, and we have a master's class, and I would love to see you guys there. And so what we do is we ultrasound all 4 arteries of the wrist, which are 2 radials and 2 ulnars. To safely do this procedure, you want a diameter of the vessel to be 0.26 centimeters. We always try to do, as we are starting the program, do an upper extremity angiogram to make sure there's no anomalous takeoff of the radial or the ulnar artery. Female gender just have a little slightly smaller arteries, and usually if you are hypotensive at the start of the procedure, it might give us a little bit of trouble. So the rationale for people ask me, why do you do that, is because in a rare case, you will see the anomalous takeoff of the ulnar artery from the brachial artery, and if you shove a 6 French sheath in, it's okay to do it, but just got to know that there is an anomalous artery. You just got to be more careful. This is so you come in from the left radial artery. I use left radial rather than the right because of a 10 centimeter advantage. You get 10 centimeters from the left radial. You come in with a Benson wire and a pigtail catheter. Usually these are the 120 centimeter pigtail catheter. US is around $18. And same, the Benson wires are probably around $15. And what you do is you're going to come down through the aortic arch, and then you're going to play this video for you. You can see literally the Benson wire is here with the pigtail catheter. Wire follows down into the abdominal aorta, and then it will go down all the way into this one here. It's in the left external iliac artery. You park the catheter here, and then you can do a runoff. It's as simple. You guys try it next week and let me know how it goes. It's a joke, guys. Okay. So the case is interesting. It's a 72-year-old male who came to see us in December in the hospital. A non-healing wound. You can see that on his left ankle. He also had one on his right. Known history of peripheral vascular disease. His right lower extremity intervention was done in the hospital by another cardiologist through the left common femoral artery access. Experience was decent, I'm not going to say, but he wanted an alternative approach if possible. He had a CTA done in December, which showed completely occluded popliteal artery. I'm going to play the CT scan, and you can see the SFA comes in the P1 segment, and then there's no popliteal artery, and then the sural artery is there. On the cross section, if you notice, you have the SFA is there, then you are occluded. You can see there's an occlusion, and there's the vessel is there, and then some vessel constitution distal. So we brought him in through the left radial artery, put a 5 French sheath in the left radial, just like I showed you, did the angiogram in the lateral aspect, and you can see superficial femoral artery coming down, completely occluded, popliteal artery, and barely flow below. That's same contrast, same everything from the SFA angiogram, and you can barely see any flow in his leg there. So what we did was we came from the radial. I crossed it into the proximal popliteal artery. I was not 100% sure, so I got a tibial artery access, put a 6 French sheath in the tibial artery, and came from below. This is an 014 wire, and this is the catheter from the wrist. And I don't have the angiogram of this one, but I'll show you the next angiogram of a different case. But this is what we did, was we just kind of think about it as a reverse order. the wire is going to go into the catheter, and then we are going to take this wire out of the body. And again, the next picture, I also don't have an angiogram, but it is of a case slightly different, but we kind of do that quite often. So if you notice, this is a dual pedal axis, both in the feet, no groin, and that's the right foot and that's the left foot. And you can see the wire is in here, goes up in the body, turns around, comes out of the other leg, and then we're going to take this catheter out. And then after we take this catheter out, the same wire that goes into the body here is an 014 wire, will come out of here. This is called a whole body floss in the lower extremity. And you can see now, just for you guys, I know you wouldn't believe me, but you can see I'm flossing the 2 arteries through the foot. So this is a floss technique or a safari technique. We do it from the radial and the pedal, but this is just the 2 legs. So you know you have to floss your legs. Then we did the reverse order here because there is no intravascular ultrasound right now available that's as long from the radial. So from the tibial axis, I went up into the intravascular crust just to make sure that I was in the true lumen, because you saw it was a completely occluded popliteal artery for the last at least 4 months. I wanted to make sure I was crossing in a true lumen because I would still treat it, but I just wanted to make sure that, so you can see it is intravascular ultrasound, shows that I'm in the true lumen. I have not dissected it. So then what I did was, so one of the senior laser people were there, and the way the lesion crossed, he said, maybe there's a thrombus there. And I said, it's been 4 months. So Orlando was there with me, and he says, I said, it's 4 months, patient has been treated. But he says, no, let's look at it, this probably is a thrombus. So I used a 2O laser from the pedal axis, went up, used aspiration. Reference vessel tibial was 3 millimeters. We did a tibial run. That's the angiogram. You can now see that there is a posterior tibial artery there. Then did a 6 millimeter balloon angioplasty of the popliteal artery, 3 millimeter balloon angioplasty of the posterior tibial artery. And then you can see the vessel is open, but there's a residual clot sitting at the tibioperoneal trunk there. Went again, did additional aspiration thrombectomy using the 2O device. Now you can see just a residual clot sitting there, little there. Now you can see the anterior tibial artery that is opened up, that was not there. Next, did multiple runs, and you can now see clearly this is the posterior. You can now see the catheter there, the wires there. The entire popliteal artery is open, tibioperoneal trunk is cleaned off, anterior tibial artery is open. And then what happened was you can now see the posterior tibial artery, the anterior tibial artery is there, and this looks good. I open up my sheath in the tibial artery and there is no blood flow. And so started looking at an angiogram and there's a blood clot sitting there. So did another run of aspiration laser thrombectomy there, and this is the final image. So you can see now all the way tibial artery is open up to the foot, and this is what we kind of got removed. You can see the amount of clot, and end of the procedure, the patient had a palpable posterior tibial pulse, so he didn't even have a Dopplerable pulse at the end of the procedure. And so this is a procedure that we did in our outpatient-based lab. I don't know how many people of you know endovascular procedures, but 2 hours later, patient walked off the table, and 2 hours later, he went home after this procedure. So that's actually called MALI, or minimal alternative access. That's what we want to do. Groin complication is between 6 to 11%, and risk of complication here from radial to pedal cases around, give or take, 1 to 1.5% on a bad day. We've done around between 500 to 700 cases of this technique, so it's not like this is our first, second. So I'll take questions, and thank you very much for having me here. questions?
On the learning curve, how easy is it to manipulate this laser?
Very easy. That's just the advantage of the laser is that the native wire is an 0.14-inch wire that I crossed. So unlike orbital atherectomy, I have to change or swap the wires out here. The wire that I cross the lesion with, I just go ahead, do an intravascular ultrasound, and then go ahead use a laser on the same one. So I don't have that. That's one of the big sellers for me, is that it saves me a few steps. And financially, it makes a big difference because a couple of things, right? You don't have to use another wire and another catheter, and the biggest value we have is time. So you saved a lot of time for yourself and the patient.
How many laser fiber are you using for a case like that?
So this was a 2.0 from the pedal axis. I've used radial 1.5s, which is, I'm told, educated yesterday, is probably the best catheter, and then I use a lot of 0.9. I do a lot, as you said, if you guys saw, I do both legs at the same time. I do tibial to tibial from AT to PT, PT to AT to peroneal. So I usually do single axis in the foot or in the wrist. I try to minimize groin complications to make things efficient, safe for the patients, and financially, you're saving between 2 to 6 hours on the patient. So.
Very impressive, thank you. Okay.